First one, a 62-year-old woman with severe knee osteoarthritis is scheduled for elective total knee arthroplasty. For post-op analgesia, anesthetist wants to perform a USG-guided femoral nerve block. And they are asking you about the anatomy of the femoral nerve according to the relation with the femoral artery. Okay, so where exactly is femoral nerve located? If you compare it to femoral artery. Now, you have to know one thing that for total knee arthroplasty nowadays, we don't give femoral nerve block for analgesia because it causes weakness of the quadriceps muscles. And what happens is right now, there are a lot of orthopedic surgeons who like to make the patient walk on the same day, do physiotherapy on the same day that they are operated. So that improves the mobility of the patient and the take of the entire arthroplasty. So what happens is that if we give femoral nerve block, it leads to quadriceps weakness and the patient can tumble and fall when they are walking. And that is why nowadays we have come up with other blocks like the adductor canal block, where you are blocking mainly the sensory nerves, or the local blocks at like IPAC at the knee, and many other blocks have come in which help in taking care of the pain related to TKR. Now, let's see what they are asking us in the question. So they are asking that we want to give femoral nerve block. How does it relate to the femoral artery? So this is a picture from Nigesora, and it exactly shows the anatomical location of the femoral nerve. Now, as you see, there are two fascia covering the femoral nerve. This is your fascia lata above, this one, and the one below that you can see over here, right, touching the femoral nerve over here, is the fascia iliaca. Okay, so this is your fascia iliaca and this is your fascia lata. Now, below your fascia iliaca, we have the femoral nerve. It is hyperechoic. Remember, it is a bright looking nerve, and it is lateral as compared to the femoral artery. Now, if you remember first year of MBBS, we had something called as the VAN structures. VAN is nothing but the vein, artery, and nerve. Okay, so you have the femoral vein over here, as you can see. Then you have the femoral artery next to it, and you have the femoral nerve. Now, is this lateral or is this medial? How do we know that? So you have to remember that your sartorius muscle always comes laterally. It goes lateral to medial. So this is your sartorius muscle. So this is lateral, and this entire thing is medial. So your femoral vein is medial, then you have femoral artery, and then laterally you have the femoral nerve. The femoral nerve is slightly posterior and lateral as compared to the femoral artery. So let's have a look at the options. Medial to the femoral artery, no. Posterior to the femoral artery, yes, but more than that, it is lateral to the femoral artery. So that is the answer I would go to. Within the femoral vein, no, that is also not the answer. So the correct answer over here is option C, lateral to the femoral artery. Approach to femoral nerve is lateral to medial. We prefer to take the in-plane approach, not the out-of-plane approach. What is the out-of-plane approach? That you're coming from above. Okay, and also remember, whenever you're giving a femoral nerve block, that you should be tracing the femoral nerve as you come above. What happens is sometimes the femoral nerve, as you go below in the thigh, it divides into two branches. So you don't want to block the individual branches, you want to block the entire nerve before it has divided. So we always trace from the knee up, right up to the inguinal crease, and inguinal ligament is the place where your femoral nerve has not yet divided. So that's where we prefer to give the femoral nerve block. All right. Now, this is something which is not a very common block given, but let's have a look at it. 38-year-old male presents with perineal and genital pain diagnosed as pudendal neuralgia. Okay. So you want to give a pudendal nerve block, which is ultrasound guided for pain relief, and you want to make sure that the spread is medial to the pudendal artery. If the injected spreads too far laterally beyond the artery, then which nerve can be blocked. Okay. So have a look over here. Now, where is your pudendal nerve and how does it look like? So here we have our sacrum. Okay, this is my sacrum bone. And here, as you know, is my ischial spine. Now, between the sacrum and the ischial spine, we have a ligament that you can see, which is marked over here. That is the sacrospinous ligament. This is typically where we give the pudendal nerve block. So they say that the pudendal nerve is present in the loose areolar tissue surrounding the sacrospinous ligament. So we want to give the block over here. And how do we identify this? So first thing that we have to do is you need to know why is pudendal nerve block given. So pudendal nerve mainly comes from the S2, S3, S4 spinal nerves, and pudendal nerve will be supplying mainly your perineal area, your anorectal area, and it is often used in females for labor analgesia. So your second stage of labor, when you want to give the episiotomy, or if you want to repair the episiotomy, then in that case, we prefer to give the pudendal nerve block. In males, you may have some pain related to the perineal area or anorectal area, so that can be treated under pudendal nerve block. Okay, so the pudendal nerve coming from S2, S3, S4 mainly supplies the perineum, external genitalia, and the surrounding structures. It is used for, as I told you, second stage of labor, vaginal repair, and anorectal surgeries such as hemorrhoidectomies. And I told you it arises from S2 to S4. Now you have to understand where does the pudendal nerve pass. Okay, so the pudendal nerve actually passes from the greater sciatic foramen. Then it comes in between two ligaments. What are these two ligaments? Sacrospinous and sacrotuberous ligaments. And then it re-enters into the pelvis through the lesser sciatic foramen, and it lies close to the internal pudendal artery and the vein. All right. Now, what are they asking? They are asking that while giving pudendal nerve block, if your drug spreads too laterally, then which nerve is blocked? So have a look at this picture over here. So this is the picture. I'm showing you the back of the patient, the gluteal muscles and the back of the thigh. And here, as you can see, that this is your sacrum and your pudendal nerve is passing over here. Okay, now lateral to the pudendal nerve, you have your sciatic nerve. This is your sciatic nerve lateral to the pudendal nerve. So any drug that I try to give close to the internal pudendal artery and where I'm trying to give the pudendal nerve block, if the drug spreads laterally, then it is going to lead to sciatic nerve blockade in the patient. Okay, so that is the answer over here. Sciatic nerve will be the answer over here. Now let's have a look at the next question. So there's a 45-year-old male with chronic gout and you want to do a 4-foot surgery. So 4-foot surgery is nothing but you want to operate the front part of the foot, anterior part of the foot. Okay, but you want to give USG guided ankle block which covers the entire foot. Okay, so you don't want that only 4-foot coverage, you want the entire foot to be covered. And what they're asking is which nerves supply the entire foot, which nerves need to be blocked so that you get a complete anesthesia for the procedure. Now, ideally, if you would want to do a procedure like this, and maybe if you want to use a tourniquet for it, what we do is we give a popliteal-sciatic nerve block. Okay, so we block the sciatic nerve. The sciatic nerve is blocked in the popliteal fossa. So this is what we try to give the patient. But here the simple question is, what are the nerves that need to be blocked? So what are the nerves that supply the entire foot? So I have given you a picture here of the sole of the foot and the plantar and the upper part of the foot. Okay, so these are the two areas which we need to see the coverage. So here, as you can see in the dorsal surface of the foot, the main coverage is of the nerve is provided by superficial peroneal nerve. This entire area marked over here is superficial peroneal nerve. Then you can see the lateral part is supplied by sural nerve. Now on the plantar surface also the lateral part is supplied by the sural nerve. The sural nerve mainly comes from the tibial nerve. It does get some fibers from the common peroneal nerve also, but mainly it arises from the tibial nerve. Then you have the first web space which is supplied by the deep peroneal nerve. So what you mainly need to remember is when we consider the dorsal surface of the foot, it is supplied by the superficial and the deep peroneal nerves and the lateral part by sural nerve. Now, when we look at the plantar surface of the foot, then it is mainly supplied by the saphenous nerve, which supplies the medial part of the foot. Saphenous nerve, as we all know, arises from the femoral nerve above. Okay. Then you have the tibial nerve, and you have the medial plantar and the lateral plantar nerve, which are also branches of the tibial nerve. Okay. The lateral part, as I told you, supplied by the sural nerve. So technically, if you want to cover the entire foot, you have to block superficial peroneal, deep peroneal. Then for medial lateral, your saphenous nerve and your sural nerve. And for the plantar surface, mainly the tibial nerve, the medial and the lateral plantar branches. Okay. So this is also a picture of the plantar surface of the foot and how it is supplied. So all of these are the innervation of the foot. Okay, I'll just write over here so that you guys know this is the plantar surface of foot. Okay, so the answer over here is superficial peroneal, deep peroneal, tibial, saphenous, and sural nerves.